أهلا بحضراتكم. My name is Dr. Mark N. Bios. I'm MD PhD in Shams University, Lecturer of Internal Medicine, Endocrinology and Diabetes, MRCP subspecialty of Endocrinology from United Kingdom, and member of the European Society of Endocrinology. Today we talk about a new topic, which is GLP-1 agonist abuse, seeing the whole picture. In this lecture, we will focus on side effects of GLP-1 agonists and their abuse and effects of this emerging problem. First of all, we say that GLP-1 receptor agonists are emerging leading drugs in managing type 2 diabetes. Examples including semaglutide, liraglutide, and exenatide. In diabetes, they improve beta cell mass, improve insulin secretion, weight reduction, and cause cardioprotective rule with low risk of hypoglycemia. Beyond diabetes, since late 2020, they have an emerging role as weight-losing medication, causing significant weight loss, changing the history of anti-obesity medications. But what happened after FDA approval in 2021? After that, an emerging problem appeared. Celebrities and social media influencers have touted its effectiveness, leading to a surge in demand, which has resulted in many people seeking prescription without medical necessity, often bypassing proper medical guidance. There has been an adorable shortage of GLP-1 agonists such as semaglutide, dulaglutide, and tirzepatide since late 2022. The shortage is primarily due to unexpected surge in demand, particularly off-label use as weight-losing drugs. The increase in demand has outpaced production, leading to supply issues. We talk also about the cost of GLP-1 receptor agonist, which varies, but on average, it's cost about 10,000 to 15,000 US dollars per year. So also they are costly drugs. So many celebrities appear on TikTok, on Facebook, on Instagram, talking about GLP-1 agonists. So there is a huge surge in the demand. It's difficult to find GLP-1 agonists because many patients use it off medical prescription as a weight-losing medication, which caused a huge problem for the diabetic patient needing that treatment. Currently, the FDA approval for GLP-1 receptor agonists for obesity started in 2021. We have 3 members approved by FDA, including liraglutide, semaglutide, tirzepatide for use in weight loss. Pharmacotherapies may be initiated after failure to lose weight, following weight regain during lifestyle intervention, or concurrently with initiation of lifestyle intervention, depending on weight loss needs of the patient. We use it with adults with BMI more than 30 kg per meter square or greater, or adults with overweight body mass index more than 27 kg per meter square with at least one weight-associated condition like high blood pressure, type 2 diabetes, high cholesterol, osteoarthritis, or lumbar disc problems. So the patient might be obese, more than 30 kg per meter square, or overweight with obesity-associated morbid condition. Okay, reports of overdoses from GLP-1 receptor agonists, mainly semaglutide, have more than doubled between 2022 and 2023, highlighting the growing issue from 1,447 to 3,316, according to data from the American Poison Center, which represents 55 poison centers across the US. Patients start on large doses of medical advice to achieve fast weight loss and don't lose their insurance coverage. Here we say a point that some insurance or many insurance companies in the USA cover treatment with GLP-1 receptor agonists. So their only point is the patient should lose more than 5% of their body weight during the first 3 months of use of the starting of GLP-1 receptor agonist. If this didn't happen, or the patient didn't achieve this weight loss goal, the insurance company would not cover it anymore. So patients try to lose weight as much as possible by starting large doses from the start so that they do not lose their insurance coverage. What about the main side effects of abuse or overdoses or starting by large doses? The main side effect of GLP-1 agonists are upper GI side effects, including nausea, which is most common, vomiting, abdominal pain. Also, there is lower GI symptoms, including constipation, which can be persistent, diarrhea. These side effects are dose dependent and class dependent, which means increasing the dose can increase the side effects, decreasing dose can decrease the side effects. Also, a member of this family can cause side effects, other one cannot, might not cause the side effect. Other side effects include dehydration, electrolyte imbalance. Some severe side effects include pancreatitis, which presents with persistent severe abdominal pain with vomiting, which can be life-threatening. Also, other side effects include increasing gallbladder stone biliary disease due to rapid weight loss and bowel obstruction and gastroparesis. And this also is important because GLP-1 receptor agonists are contraindicated in diabetics with gastroparesis. It can cause bowel obstruction. In abuse and overdoses, also they can cause hypoglycemia. Typically, there are euglycemic agents that don't cause hypoglycemia, but in overdoses, hypoglycemia, electrolyte imbalance, nausea, vomiting, all of these can occur. Another point we say that there is compounded version or generics of semaglutide that are most were likely for causing many of the adverse effects or overdoses. This was common in the USA using semaglutide salts, not approved by the FDA, as an alternative to semaglutide and other GLP-1 receptor agonists. So what about managing these GIT side effects? First of all, we say dose adjustment, decreasing the dose, and gradual up titration can stop many of these side effects. And patient can reinitiate and re-increase the dose, but gradually. We can try an alternative GLP-1 receptor agonist. There is variation to GIP tolerability profile between GLP-1 receptor agonists. Also, we can shift from short-acting to long-acting GLP-1 receptor agonist. If patient fail on all of these or cannot tolerate GLP-1 receptor agonist, we shift to another class of obesity pharmacotherapy and the drugs to be stopped. But let's talk about another issue, long-term effects after cessation of the GLP-1 receptor agonist as an anti-obesity medication. We talk here about the STEP 5 trial, which was implemented in November 2021 and its extension. The STEP 5 trial assessed the efficacy and safety of once-weekly semaglutide 2.4 versus placebo, both plus behavioral intervention for long-term treatment of obesity, not diabetes. And actually, it was like magic. Semaglutide caused significant weight loss in 15.2 of the treated group in compared to 2.6 with placebo on lifestyle modification only. So it caused significant weight loss. This was very bright results from the STEP 5 trial. Conclusion says that semaglutide treatment led to substantial sustained weight loss over 104 weeks versus placebo, as we see here in the graph. The placebo 2.6 and the semaglutide 2.4 milligram weekly dose 15.2. What about after stopping of semaglutide treatment? This was an important issue, and that was the extension trial, STEP 1 trial, which was an extension trial for 1 year after off treatment, after stopping of semaglutide, and the effect on that on weight loss. An off-treatment extension assessed for further year represents subset participant who had completed 68 weeks of treatment following treatment withdrawal of semaglutide and placebo participant regained weight, the semaglutide arm regained 11.6%, and the placebo regained 1.9% of their lost weight, which means from the 15% that lost weight on semaglutide, 11.6 regained the original weight within only 1 year. As we look, the first half of the graph is the step 5 trial, and the continuation of the graph is the continuation of the extension trial, step 1, or going back to step 1 after stopping the anti-obesity semaglutide medication. We here see the upsloping of the curve and return 11.6 returned to their original weight before using of semaglutide. So what we try to say here is looking on the whole picture after stopping semaglutide changed a lot of the picture. Semaglutide stopping caused significant weight regain, rapid weight regain within 1 year, nearly to most of the participants who first lost weight on semaglutide. Results of the extension trial: cardiometabolic improvements seen from week 0 to week 68, and with semaglutide reverted toward baseline at week 120 for most variables. Weight regain was comparatively rapid following semaglutide withdrawal compared with other anti-obesity medications. Participants regained two-thirds of their prior weight loss with similar changes in the cardiometabolic variable. Finding confirms the chronicity of obesity suggests ongoing treatment is required to maintain improvement in weight and health, reinforcing for the need for continued treatment to maintain weight loss and the cardiometabolic effect. This is an important issue. So if you want to continue on your weight loss or your new lower body weight, you should continue on the GLP-1 receptor agonist. Stopping them would cause regaining of the whole weight loss and lead to a rebound obesity. So this was an important result of the extension trial, and the conclusion was you should continue on semaglutide treatment, not stopping after reaching the target weight. So what about another side effects after the extension trial? We also talked about what we see as accelerated facial aging. This review studies relationship between GLP-1 receptor agonist, adipose tissue, and premature facial aging. That study was about studying the effect of GLP-1 receptor agonist on facial fat. Using GLP-1 agonist caused increased aging, increased signs of aging, loss of fat from the face, hollow out appearance, and even lipodystrophy. A new term that is rising, which is called the Ozempic phase. The Ozempic phase is an accelerated aging phase with loss of the facial fat attributed to over doses and using semaglutide for long time. It's called the Ozempic phase. It's due to accelerated facial aging. Another side effect that appear on using GLP-1 agonist for a long time were behavioral changes and psychiatric aspects on prolonged use. The potential to make life boring and miserable may be an unwelcome side effect of a GLP-1 receptor agonist. This medication can alter the way food tastes, even drive the ability to drive pleasure from activities. Also, there is an important issue, which is psychological dependence. Patients are afraid to stop, or even with serious side effects or annoying side effects, patients are afraid to stop GLP-1 receptor agonists. Also, using GLP-1 agonists, people don't adhere to a healthy lifestyle. They depend on the drug to for their weight loss. And, also, some drug addicts adhere to GLP-1 receptor agonists to decrease sense of pleasure and craving. So, regarding psychiatric and behavioral changes, many aspects were noticed on prolonged use of GLP-1 agonists. So, another point, GLP-1 receptor agonist and thyroid cancer. Okay, the idea here is that some tissues express GLP-1 receptors. So these tissues in rodents include thyroid tissue. Using high receptor GLP-1 receptor agonist caused elevation in plasma calcitonin and C-cell hyperplasia in rodent in a dose-dependent manner. This issue is not seen in monkeys or humans because thyroid C cells do not express GLP-1 receptor agonist, except for patients with familial medullary thyroid cancer. 27% of these patients were found to have GLP-1 receptors. So that's why the current advice is of guidelines says that GLP-1 receptor agonists are contraindicated in patients or family history of medullary thyroid cancer or in patients with MEN type 2 syndrome, which causes familial medullary thyroid cancer. So another recommendation is to be cautious when using them in any case of familial thyroid cancer. Uh, Studies up till now have not reached an endpoint regarding long-term use effect of long-term use of GLP-1 receptor agonist on follicular cell. So another precaution is that be cautious when using GLP-1 receptor agonist in patients with familial thyroid cancer or familial adenomatous polyposis, Carney complex, Vermeer syndrome, familial papillary thyroid cancer. Okay, we look at the right side, we see another tissues that also, another types of tumors that express GLP-1 receptor agonists, but still no sufficient studies about the effect of using GLP-1 receptor agonist on these tumors, including prostatic cancer, ovarian adenocarcinoma, neuroblastoma, nephroblastoma, medulloblastoma, pheochromocytoma, and meningioma. All of these tumors express GLP-1 receptor agonist for further research and to know the outcome and the effect of GLP-1 receptor agonist on these tumors. So we talked a lot about side effects. Let's talk about indications according to the ADA 2024. What does the ADA say? Okay, let's say first point that the GLP-1 agonists are not all the same. That's the point that the ADA emphasized on in 2024. We see here the hierarchy of management of type 2 diabetes. If the patient is cardiac or atherosclerotic cardiovascular risk or have atherosclerotic cardiovascular disease or patient on CKD, so GLP-1 receptor agonists are important, but only those with proven cardiovascular effect or proven cardiovascular benefit. The ADA tells us that liraglutide, high-dose dulaglutide, and only injectable semaglutide have this cardiovascular protective rule. This is due to studies made, what we call the cardiovascular outcome trial, CVOT. So all of the recent anti-diabetic drugs have been studied for their effect or their cardiovascular outcome. Only those with preventive or protective outcome are indicated in patients with cardiovascular risk. So this includes liraglutide with the leader trial concluding 13% relative risk reduction in the primary composite, which was death from cardiovascular cause, non-fatal MI, non-fatal stroke. Then the placebo group, also dulaglutide showed REWIND trial showed 12% relative risk reduction. Injectable semaglutide sustained trial showed 26 relative risk reduction. Some other GLP-1 agonists didn't show efficient or sufficient cardiovascular protection, including Excel trial, exenatide, Elixa, or oral semaglutide pioneer trial. MACE showed non-inferiority but non-superiority. Hospitalization was the same in both groups, the placebo and those treated with those GLP-1 agonists. Another important point is that also the ADA tells us that there are some of these agents have very high efficiency for glycemic control, including high dose dulaglutide, semaglutide, tirzepatide. Also, some of these agents have very high efficacy for weight loss than others, including semaglutide, tirzepatide. High efficiency, less or not after very high efficiency, we find high efficiency for weight loss, including dulaglutide and liraglutide. GLP-1 receptor agonist with proven cardiovascular protection and renal protection, including liraglutide, high-dose dulaglutide, and injectable and only injectable semaglutide. So, at last, we talk about an important issue. What about using GLP-1 receptor agonist in type 1 diabetes? So far, studies show that this medication can lower A1C and help weight loss in patients with type 1 diabetes by decreasing satiety and decreasing gastric emptying, but yet they are not approved by the FDA for treatment of type 1 diabetes, and these are used off-label after discussion with a specialist as a weight losing medication using their satiety mechanism only. What about GLP-1 receptor agonists in children? Okay, in 2020, liraglutide received the FDA approval for obesity treatment for children with BMI more than 30, more than 95th centile of obesity. In 2023, semaglutide after liraglutide approved FDA approval. Also, a GLP-1 agonist can be used in children with type 2 diabetes who are at least 10 years old. That was accomplished since 2019. So they can be used in children with obesity after failure of lifestyle modification. The only setback is that the GIT symptoms were found to be more severe in children than adults, but this didn't prevent FDA from their approval. So take-home message, healthcare provider may play a crucial role in stopping abuse of semaglutide and other GLP-1 agonists. They must ensure that the prescriptions are given based on medical necessity, providing thorough guidance for proper use of this medication, gradual up titration, not starting on big doses from the start, monitoring for their side effects, telling their patient that lifestyle modification is important and stopping the drug, they might regain their weight loss. Education patients about potential risk and long-term impact is essential to prevent misuse. Okay, thank you. And at last, we want to say that it's very important to eat healthy, to live a healthy lifestyle, and to eat less, to practice physical activity and exercise. This is the easiest and cheapest and most healthy way of losing weight. It will not cost you $10,000 to $15,000 per year, and it's much more healthier. Thank you, and till we meet again in another lecture.